This is a presentation on the ultrasound diagnosis of Caesarean scar pregnancy. I'll be talking about section scars and niches, the definition of a scar pregnancy, some controversy, and differential diagnoses. A Caesarean scar pregnancy is a type of uterine ectopic pregnancy where the trophoblast has implanted into a Caesarean scar niche where there's no decidua. The incidence is around 1 in 2,000 pregnancies, and the risk increases with the number of previous sections. Most of these scar pregnancies will fail in the first trimester, but those that continue will develop into placenta accreta spectrum. The orientation of my images is always like this, so it's as though the patient is lying down like this: anterior wall, fundus, posterior wall and cervix, with the bladder up there. And so in this case you can see 2 Caesarean scars. In this example you can see 3 separate section scars, and you can see in this video clip 2 section scars. There's just one there and one there. A normal intrauterine pregnancy in a uterus with a section scar looks like this. There's the scar, there's the intrauterine pregnancy, and there's a good little distance between the two. But if the uterine scar hasn't healed very well, it can become a niche, and this is what a niche looks like, and how to measure them. So you can see that in the longitudinal plane going side to side, there's a defect in the myometrium, which in the longitudinal plane looks like this, and then transversely it can be much wider still than that. You can measure them like this. That would be the length, and that's the depth and the width in the transverse plane. And you can measure the overlying residual myometrial thickness and the adjacent myometrial thickness, and that gives you an idea for the size of the niche. If the niche is large, as in this case, it can cause intermenstrual bleeding. And in this video clip you can see how you can get a collection of menstrual products in the niche, which can then leak out as intermenstrual bleeding during the rest of the cycle, and this fluid can affect the implantation of embryos. So in a niche you have deficient endometrium, and in a scar pregnancy the placenta attaches itself deeply into the myometrium because there's no endometrium there. You can see here that this is the scar niche, and the white trophoblast attaches through the myometrium, through the fibrous scars, into possibly surrounding structures. And you can see in this beautiful diagram from Silver and Branch that this is the placental tissue, and it normally implants onto decidua and not onto the myometrium. But if you don't have any decidua, then the placenta becomes abnormally adherent to the myometrium, or it can grow into it or through it right the way to serosa, and that's accreta. But these 3, accreta, increta and accreta, together constitute placenta accreta spectrum. So the green top guideline showed us that you can get massive postpartum hemorrhage in association with placenta accreta spectrum, and that the vast majority of these are the consequence of low placentation into a previous section scar. So what exactly is a scar pregnancy? It's a pregnancy implanted into the niche of the previous section, and we diagnose these on transvaginal ultrasound with a partly filled bladder to give you a better contrast in this area. You need some experience of diagnosing these, and it's much harder to diagnose a scar pregnancy after about 7 or 8 weeks, as this pregnancy becomes intrauterine, and at that point you have an intrauterine pregnancy and you have to try to imagine exactly where the placentation is. In 2016 we got this green top guideline on how to diagnose scar pregnancies, and the criteria include an empty uterine cavity, then trophoblast embedded at the site of the previous section scar, with thin or no myometrium overlying it, prominent Doppler colour flow, and an empty cervical canal. And that's what it all looks like on this image. This is an anteverted uterus. An empty uterine cavity, especially prior to 8 weeks, is there. Closed cervix and empty canal there. You can see it better in the next few images. The placenta or gestational sac embedded there, embedded in the niche, so a negative sliding sign, with thin or absent myometrium and functional trophoblastic flow on colour Doppler like this. So here again, the empty upper cavity and empty cervix. There's the niche with the embryo implanted there. And this is a line that you can draw to see, is it in the uterine body, in the uterine cavity, or is it in the cervix? Where the bladder attaches to the anterior cervix, there's the internal os, and behind that is the torus. But this line shows cervix and uterus. So a scar pregnancy should be above this line. There is strong vascularity, indicating that the trophoblast is embedding in this area. It's not a miscarriage, with thin overlying myometrium showing a very deficient niche. And this is an important sign. You can often see a triangular sac just like that, and that's where the gestation sac is drawn into the niche as the trophoblast is above it. So what PRF should you use? Most papers don't really tell you an exact PRF, just say that it has to be prominent flow. Papers, if they quote something, they'll say a velocity of 20 centimeters per second, but that's the peak systolic flow in the largest vessel in the area that you're looking at. Where we're really not doing that, we're using the morphology of colour flow, and so I use a PRF of 0.6, sometimes 0.9 to estimate the degree of implantation. And in this video summary again, these diagnostic features are demonstrated. So you can see that the cervix is empty just there. You can see the endometrial cavity is empty. And there's this low implanted pregnancy in the niche. You can see as I very gently press that there's no movement, that's embedded there. And that therefore fulfills these 4 criteria. And on the colour Doppler, you can see this is it without colour, this is it with colour. You can see that this trophoblast is embedded very low in the anterior uterine wall. So just the difference between an anteverted uterus and a retroverted uterus. In an anteverted uterus, you've got the scar is there, and the scar pregnancy is just implanted in the niche. In a retroverted uterus, the uterus is pointing away from the bladder is up here, so the Caesarean scar is there, so that's where a scar pregnancy will occur. In a retroverted uterus, it's just there. A failing scar pregnancy can be just an empty gestation sac, as in this example. Residual myometrial thickness very thin there, a closed cervical canal. This is the line that I was talking about below, which is cervix. And you can see that it's not a miscarriage passing through, it is embedded mainly posteriorly. And on repeat ultrasound, the sac remained empty and she had an uneventful surgical management. Or you can have a failing scar pregnancy with trophoblast only, and in this 3D example, it's an anteverted uterus, anterior wall, fundus, posterior wall, empty endometrial cavity, and this massive trophoblast that is protruding anteriorly through the serosal line. On 2D, you can see how vascular it is. She was given methotrexate and it became much more vascular and larger, which can happen. And the residual trophoblast became infected 2 months later and it took another month for it to begin to resolve. Our experience of scar pregnancies over the last 10 years, here are 10 examples, where in yellow at the top I've written the residual myometrial thickness at the time of presentation. And these 10 in niche scar pregnancies were all diagnosed early. They were all delivered at more than 27 weeks gestation. 8 of them had a Caesarean hysterectomy, 1 a section with a B-Lynch suture, 1 a section with partial myometrial excision. And the estimated mean blood loss was around 6 litres, and 8 out of 10 of these had histology showing placenta accreta spectrum. To choose one example, this patient had had 3 previous Caesarean sections, and you can see here the pregnancy is embedded low in the niche, empty cavity, empty cervix, and you can see as the pregnancy continued, even at 9 weeks, the cavity is still empty near the top, thin residual myometrial thickness. At the time of section, you can see this very, very thin lower segment with these very large abnormal vessels where the trophoblast has grown through the scar. And on histology, the placenta is embedded straight onto serosa, and this was a Caesarean hysterectomy with placenta accreta. Some people's section scar is very high, and this is an image showing 7 months after the first section for failure to progress. And when she became pregnant 5 years later, she had some spotting, and you can see that's where the scar is, and this placenta is just embedded over the top of it. And when it came to her caesarean section, she had a bilobe placenta, and there was a little lobe here that was placenta accreta attached to a high deficient old section scar. This lady had 2 prior sections, came with severe pain and heavy bleeding. She had a caesarean scar pregnancy. You can see it's embedded there, so it ticked all the diagnostic criteria. And on longitudinal view, there was something behind the cervix. And when the sonographer looked more carefully, this was a mass separate to the ovary, and it was in fact tubulectopic. So the patient had a left salpingectomy on the same day, and she wanted to continue her scar pregnancy and had a caesarean hysterectomy at 27 weeks after spontaneous rupture of her membranes, and had placenta accreta. So this was a heterotopic scar pregnancy. In patients with a subseptate uterus, this patient had 3 sections. This was her normal intrauterine pregnancy, another breech, another section. And a year later, she conceived again, and the pregnancy was lower this time. On 2D, it was a scar pregnancy, and she had surgical management. And a year later, she had another scar pregnancy. This one was uncertain viability. And this is the 3D of that pregnancy. We don't diagnose them on 3D. This is just what it looks like on 3D. And she had an uneventful surgical management. Twin pregnancies, one of them can be a scar pregnancy. Like in this case, we've got twin 1 and twin 2. You can see that this trophoblast here is deeply embedded. And it's you can prove it on Doppler. This pregnancy failed, and the other pregnancy was delivered by caesarean uneventfully. And in the second case, again, twin 1 and twin 2, and you can see what that looked like a few weeks later. Thin overlying myometrium, but this pregnancy then failed, and the other baby was delivered at term with a small PPH. The placenta can be posterior in a scar pregnancy, and this is an example of this. So this is at 6 weeks gestation, a patient with 3 prior sections. You can see again empty cavity, empty cervix. You can see the niche there with trophoblast in it, and there's colour flow just there. You can see that there's a suggestion, even so early, that there is some posterior placentation. By 8 weeks, you can see it's clearly in the niche and posteriorly. And then you can see at 20 weeks, the placenta was posterior up and over into the niche anteriorly, and that continued. And she ended up with an APH and a caesarean hysterectomy, and the histology showed placenta accreta. Bulging can be a bad sign, particularly if it's combined with strong vascularity. And in this case, this is an 8-week gestation. This is the anterior wall. This is the rest of the uterine body in an empty cavity. And you can see here this massive trophoblast. This is at 8 weeks gestation. By 10 weeks, she had bleeding and a severe pain. And you can see that if you draw a line from cervix to uterine anterior wall, that this is sort of breaching the serosal line, so it's bulging. And in this video clip, you can see that most of the pregnancy is very abnormal, very vascular trophoblast, but with a live scar pregnancy. You can see just how vascular it is, even on a higher PRF that shows less blood flow. You can see this very strong vascularity. And over the next couple of days, the patient got more pain, opted for surgical management, but that then resulted in a hysterectomy with heavy blood loss, and the pathology showed placenta accreta. You can have a failing scar pregnancy that still fistulates with the uterine artery. And here this patient had 1 prior section, and you can see here that there is trophoblast which bulges out towards one side. I'm going in the longitudinal plane from one side to the other. You can see that was all trophoblast, and to the other side it's not. And there's the empty cervix below it. And on 3D, it's very obvious that this massive trophoblast is bulging out to the right side of the uterus, and that was very vascular, just at the level of the uterine artery. When I did a 3D render, you can make that into 4D. You can see that the trophoblast is extremely vascular and that it has become a fistula with the uterine artery. This patient opted for conservative management and was given Depo-Provera, and even 5 months later there is still some trophoblast. The patient's entirely asymptomatic, and so it's hoped that this will resorb in time. Then we now see what in the niche scar pregnancies are. We've been looking at those, but how about on the scar? The original definition from the RCOG was a scar pregnancy had to be at the site of the scar. Then this paper in 2017 talked about on the scar or in the niche Caesarean scar pregnancies, where in the niche CSP is what we've been talking about, a placenta implanted into a niche. But possibly on the scar pregnancy would be placenta implanted on top of a well-healed scar, like that example we just looked at, a thick scar but with placenta over the top of it, and these were shown to have a much better outcome. In 2020, Eshrey then gave us some definition for scar pregnancies, which was again implanted in the section scar, and not really talking about in or on. And I was listening to Professor Hauner in October, and she is just publishing a sonographic reporting system, so I don't know what it will end up saying exactly, but again saying that a scar pregnancy is an implantation in the scar defect of two kinds. One is largest part embedded in the myometrium, and this one the largest part toward the endometrial cavity, and maybe that's talking about in niche and on scar. It's not entirely clear. So if I looked at some of our possible on-scar pregnancies, here is 10 examples, and these patients all did very well. They had caesarean sections and normal vaginal deliveries. There were no caesarean hysterectomies here, and not many postpartum hemorrhages. So just taking one example again, so thick myometrium, 2 previous sections. You can see that there is some implantation over that scar, and that it's embedded in that area. Empty uterine cavity above, anterior cord insertion, you can just see the cord just there. So is it a scar pregnancy? The uterine cavity and cervix are empty, it's embedded at the site of the scar, functional trophoblastic flow, but not a thin myometrium, so not a scar pregnancy. And this patient had a caesarean section and did not have placenta accreta. But if you're going to call something an on-scar CSP, you have to be very careful not to say that too early, because here's an example of an on-scar becoming an in-niche CSP. At literally 4 weeks and 5 days, we could see a little sac just here with a thick section scar. By 5.5 weeks, again, it's a scar pregnancy, but the section scar was 4.5 millimeters, so nice and thick. So this was called an on-scar. But then as we go nearer to 8 weeks with a repeat of the ultrasound as well, you can see trophoblast, and it wasn't exactly clear what the RMT was. And on this repeat, it was easier to see. There's the trophoblast, and you can see there's the abnormal placentation, and the RMT was very thin. By 10 weeks, you can see very strong anterior flow. By 13 weeks, again, you can see this placentation, which is very strong, and on TA you can see that it's anterior and posterior. And this patient ended up with a caesarean hysterectomy and a placenta per accreta. So even though the very early days it looked like it was going to be an on-scar pregnancy, by 8 weeks it was an in-niche scar pregnancy. So the differentials are low implantation, where the placenta is just near the scar, a miscarriage, or a cervical pregnancy. So near the scar or on the scar, really difficult. This is 6 weeks gestation. This is 7 weeks gestation. You can see empty cavity above, empty cervix. You can see the section scar there. You can see placentation is low. 9 weeks, and here we are at 11 weeks. 13 weeks, the placenta is moving up and up, and this patient had a forceps delivery, so this was not a scar pregnancy. And how could we have known that? If you look in the early images, you can see decidua. You can just see endometrium there, and then the decidual sac is separate from it. So if you can see decidua in the early scans, it's got to be near the scar, not in the niche or on it, and it's just low implantation, but it can be difficult. Miscarriage in process, this patient with uncertain dates, you can see again, you can see a low sac, but really minimal vascularity. And when she was scanned a week later, this sac was sliding in the cavity, minimal vascularity, and it was a delayed miscarriage, which resolved completely. So there, and minimal vascularity and sliding, it's not anchored, it's a miscarriage. And a cervical pregnancy is a pregnancy below this line that we were talking about, with the pregnancy in the cervical canal. And you can see it's deeply anchored there. A week later, though, it started to fail, and another week later, it was continuing to fail. The patient was managed conservatively, and it spontaneously resolved. So if the pregnancy is below the internal os, it's in the cervical canal, it's a cervical pregnancy, not a scar pregnancy. So in summary, it's a scar pregnancy if you have an empty uterine cavity and an empty cervix, if your trophoblast is embedded in the scar niche with no sliding, thin myometrium and functional colour Doppler flow. It's an in-niche scar pregnancy. Be very careful with pregnancies that are on or near the scar. Because we still don't know everything about scar pregnancies, the Scar Pregnancy Register was set up, and this is their PI, Andrea Kaelin-Acton. And they're collecting data through their website, which will give us more on the natural history, and we can work together and work out how best to manage such cases. There are 6 centres in the UK already collaborating with them, and we're one of them, and they've already got 581 cases. So if you would like to join them, just email them through the website. So in conclusion, ask your patient if she's had a previous caesarean section. You need a good ultrasound machine, and niches and scars can be difficult to see and varies with gestation. Try and do the scan by 8 weeks, because after that it's much harder to diagnose, and the residual myometrial thickness can be difficult to measure, but don't include the trophoblast. Look for decidua between the gestation sac and the myometrium, because then it's unlikely to be a scar, and look for this teardrop gestation sac, a little triangle. If it's thin overlying myometrium, be very careful, but we don't really have a range of what's normal at what gestation. But look also for strong vascularity and bulging. Discuss cases at your multidisciplinary team meetings, and arrange for a repeat scan by an expert if you're not sure. And remember that an apparent on scar early on can become an in scar one, and also that an apparent on scar pregnancy might just be low implantation, so the stakes are very high to get it right. And it's probably not one single entity, but a bit of a spectrum somehow. You need always to record the early pregnancy findings in the obstetric notes, so that the obstetricians know what you thought about it in the first trimester. And even if the second trimester then doesn't show placenta accreta spectrum, the placental bed might still really bleed due to these large vessels that can't contract. So I'll finish by saying what Embrace told us in 2018, that there has been a near doubling of maternal death rate from hemorrhage, almost entirely due to this abnormal placentation. And they suggest that if somebody's had a previous section and has placenta previa or an anterior placenta under the scar, you should manage them as if they have placenta accreta spectrum. Thank you.